The Canadian Cancer Trials Group CO21 Challenge trial is the first randomized trial in the world asking the question whether exercise can improve cancer survival. The study was launched in 2008, so many years ago, and the rationale for doing it was based on observational data that was published in 2005 and 2006, suggesting that exercise following a diagnosis of colon cancer may reduce the risk of cancer relapse. And we felt at that point it was important to test this empirically with a randomized trial. In this randomized trial, patients with colon cancer who had completed surgery and adjuvant chemotherapy were randomized to one of two arms. The control group received an exercise booklet encouraging a healthy lifestyle and exercise. The experimental arm received the same materials but also received a funded personal trainer life coach for 3 years. This physical activity consultant worked with the patient over 3 years to increase their levels of exercise. The target was to increase their exercise 10 MET hours above their baseline. A MET is a unit of energy, and to put this in context, going for a brisk walk for 1 hour would count as 4 METs. So the physical activity consultant would work with the patient to come up with an exercise prescription based on their lifestyle, interests, and other activities they like to do to increase their exercise and hit that 10 MET target. This was done initially in the first 6 months, ramping up using behavior change techniques. The physical activity consultant would meet with the patient every 2 weeks for a motivational coaching session and then for a supervised exercise session. In year 2 and year 3, this became monthly, and the primary endpoint was disease-free survival. Patients could choose any time of aerobic exercise, everything from swimming to biking to kayaking and skiing, running or walking, but the typical patient would choose a walking program, and if they went for a walk, a brisk walk of 45 to 60 minutes, 3 or 4 times a week, they could hit their targets. So the key results really are quite astounding. We found that patients that were provided the structured exercise program and physical activity consultant had a substantial increase in their exercise. They also had an important improvement in their physiologic measures of fitness, VO2 max, and a 6-minute walk test. But the really remarkable results were related to survival. When it comes to the primary endpoint, disease-free survival, there was a 28% reduction in the risk of recurrent or new cancer with exercise. This translates to a difference in 5-year survival of 74% for the control group and 80% for the exercise group. What this means in pragmatic terms is that for every 16 patients who went on the exercise program, exercise prevented 1 person from developing recurrent or new cancer. The overall survival results are even more impressive, with a hazard ratio of 0.63, a 37% reduction in the risk of death. This translates to 8-year survival rates of 83% in the control group and 90% in the experimental arm. Again, putting that in pragmatic terms means that for every 14 patients who went on the exercise program, exercise saves 1 life. The policy and practice implications of this study are profound. I believe this sets a new standard of care, and that exercise is no longer just something that can improve quality of life and fitness for cancer survivors. It is now a cancer treatment that improves survival. The important part of this is going to be the translation into practice, because knowledge of these results in themselves will not likely be sufficient to allow most people to change their lifestyle. So we need health systems and hospitals to invest in providing this behavior change intervention and these exercise specialists to support patients so they can make these lifestyle changes. Ultimately, this intervention is empowering for patients, the goals are achievable for patients, and compared to many of our cancer medicines, the costs are very low, and so this is sustainable for health systems.